What is going on?
Okay, let me get a patient, please.
Not my turn.
I'll do it.
All right. So today we're going to do C-spine. So first things first, for all the C-spine views, we're going to use a 12 by 10. It's going to be in there lengthwise, so 12 top to bottom, 10 side to side. This is not very tight in there. Okay, so the first view we're going to do is going to be the AP axial C-spine. Okay, so Milo's going to put his back against the board for us. We'll bring this up quite a bit. Your angle is 15 to 20 degrees. Okay, so we're going to angle 15.
Was your image receptor the right way?
Yeah, so that.
Oh, okay. It looked the other way around for some reason. Never mind. Ignore me.
Okay,
We're doing the AP axial.
AP axial. So 15 degrees, 15 to 20 degrees cephalic. And then we're going to open our light field to be 12 top to bottom on the 40-inch line. And then no more than 10 side to side. So I'm going to set it at 12 by 10. We'll adjust from there, okay? So the first thing you want to do, want to have your patient stand up nice and straight. We want the chin up, but not like super up. So I like to just say like kind of stand up like you're standing up with good posture, okay? So bring your chin up a little bit. If the chin comes too far up, then the base of his skull is going to come down over the vertebrae. And then if the chin is down, we have a whole bunch of superimposition of the jaw. Okay, so with our 15 to 20 degree angle, we're coming up to come under the jaw and have as minimal superimposition as possible. Okay? So our centering is at C4, so that's about at the Adam's apple, and your head is like still a little bit too far back. There you go. Good, you want your patient to be as flat against the image receptor as they can be. And then we're gonna bring this up so that we're lined up right about there. And then markers for the spine. So we're not looking at the left or the right side of the body, right? We're looking at the body as a whole. So this is kind of like the pelvis. Just make sure you mark the proper side of your patient, okay? So a left marker over on this side, which is there. You can roll the shield in front of him here. And then he's going to just hold his breath. The book says to tell your patient not to swallow, but if you all hold your breath, you can't really swallow while you're holding your breath anyway. So I've never said that to my patient and never had an issue with it. So this would be the AP axial. With him, I can collimate a little bit top to bottom. We want to make sure that the top of our light field is coming above the ear, above the EAM, and then that we have at least a little bit of light below that sternal notch, okay? That jugular notch of the sternum. So that's good collimation wise there. Collimate a little bit side to side. There's an AP axial. Okay, questions about that one? All right, I'm gonna go ahead and move to the open mouth view. I'm doing you guys' lab a little bit different just because I want to put the three that are on practicum together. So there's the AP axial. I take my angle off and close my collimation top to bottom quite a bit. Yeah, you can take your mask off. So what we're wanting to do here is I want you to feel behind your ears, and there's bony bumps behind your ear. Do you feel that? And then the bottom of the top teeth, we want to get those in line with one another by rotating the head. Okay, so what I'm going to do is I'm going to feel, I'm going to bring this up first, stand up straight. So I'm not even going to have him open his mouth yet. I'm going to put my fingers back here behind here. I'm going to push on his cheeks here. Tilt your head down. Right about there, his teeth here are in line with those bony bumps, okay? I'm gonna keep my hands on his face and tell you to open your mouth for me as big as you can. There you go.
So you're just trying to make it like parallel or horizontal, like with
Perpendicular.
Yes, you want it to be
Yeah.
parallel with itself so that
Parallel.
it's perpendicular with the image receptor.
Okay.
And then we're centered coming into his mouth. Collimation's good. When I go to take my image, I tell my patient to say ah to get their tongue down out of the way. Okay? So,
I like that. Sounds weird. Feels weird too.
Okay, you can put your mask back on. But so that's the position for that. So the whole point here is what we're doing is we're getting the base of the skull in line with the roof of the mouth so that when the patient opens their mouth, we're seeing that odontoid process free of superimposition of the teeth and of the base of the skull. Does that make sense?
Mhm.
So that's why you're rotating like that to get it all in line. So when we're done with the video, I'll have you guys all kind of come and feel how it feels, okay? So that's the open mouth. So the apiaxial, the open mouth. Now we have to come out to 72 inches. Milo's gonna turn and face the left for me. Put his left side against the image receptor. So for the spine, all spine laterals are done with the left side against the board. I don't really think there's a reason for this. I think that the chest, there's a reason because we're getting less OID of the heart. So I think for everything else, they were like, well, we'll just keep everything left lateral, okay? So left side of the body against the board. Can anybody guess why we come out to 72 inches?
Because of the height of the image receptor? Do you want a longer?
No, think
Get
about
up against the wall.
look at how far his spine is from my image receptor. I can't do anything about this OID, right? But I can't cut his shoulder off. I can't do anything about the OID. So when we bring our SID out, it compensates for OID, okay? So for every 6 inches of SID, we're compensating for about 1 inch of OID. So when we add 32 inches, we're compensating for about 5.5 inches of OID so that we don't have a whole bunch of magnification. All right, so that's what happens here. So or OID that we can't do anything about, we bring our SID out. Okay, so 72 inches. Now it's important for your collimator to be adjusted to the most outward line, that's the 72-inch line. All right, so again, I'm gonna set it 12 top to bottom. Side to side, I'm gonna open it for now, just because I can't see my little lineup light on here otherwise. So I open it up so I can see to line up my image receptor. And down a little more, right about there. Now I'll close it down side to side. Again, we want the top of our light field to be at the EAM, the external auditory meatus. And then we want light field here on the side. So make sure your patient's head is straight forward, chin up a little bit again. And then it's important on the lateral that your patient relax their shoulders down. So breathing instructions for the lateral are blow your air out and hold it out. And that hopefully relaxes the shoulders down. If your patient's shoulders don't drop and they're not in a lot of pain, I could have him hold sandbags to get his shoulders down because we're needing to see all of the C-spine. Well, his C7 is right here. So sometimes when you have a patient with thicker shoulders, it's harder to see that entire C-spine. Okay, so the other thing I like to tell them is to like try to relax and reach towards your toes. That sometimes can help. Or sometimes we have what's called a swimmer's view that we can add to our routine to specifically view C6 through T2. So it looks at that space between the shoulders. And we'll learn that view next week with thoracic spine, okay? So that's our lateral, 72 inches, still centered at about C4, making sure he's nice and straight, and then blowing the air out to help relax the shoulders down, okay? Questions about any of those three? So those are the three that are on the practicum, okay? I'm gonna show you guys some specialty views now as well. So the first one I'm gonna show you is we stay at 72 inches, and this is called flexion and extension. These are to view the patient's ability to move their neck, okay? So sometimes it's done after a patient's had surgery. Sometimes it's done if they're having arthritic issues, or sometimes it's done pre-surgery so that they can see if there's any bone they can shave off or anything they can do to help gain more motion in the neck, okay? So he is in flexion, so look down as far as you can, just like that. We can turn our image receptor to match the patient's anatomy, like so. So that's flexion. And extension, he's gonna bring his head as far up and back as he can. Same thing, now we can scoot forward some. Right about there. Sometimes it's nice to like let the patient put their hand on the shield, especially older patients seem to get dizzy doing this. So they can put their hand on the shield to hold themselves steady, okay? So that's flexion and extension. You'll do those pretty commonly, but there's not a lot to them. And if they do want those, they want a normal lateral too. So you do a neutral lateral, and then flexion, and then extension, okay? Let's see, I'm gonna put your back against the board again. A specialty view to view the odontoid process if your patient can't open their mouth, or maybe they have like implanted teeth and it's causing superimposition and you can't like see through the teeth or whatever, you can do what's called a Fuchs method. The Fuchs method, we have to get the MML perpendicular with the image receptor. Okay, so the MML is the minto-meatal line. So the tip of the chin to the ear hole has to be in a perfect line to come back to the image receptor. So your patient's gonna bring their chin way, way up. Let's see, I'm gonna give this little thing. And this is in line. See the tip of his chin to his ear is perpendicular with the image receptor. Okay, so we would have it just like that. I'm gonna bring this up a little bit more because our centering is gonna be just below the tip of the chin. Okay, so just like that. I open this up so we have room for a marker. And what this is doing is bringing the base of the skull back so that the foramen magnum at the base of the skull is sitting here, and we're seeing that DENS process through that foramen magnum. All right, this can also be done with trauma patients if they're in a C collar. If they're in a C collar, a lot of times they're gonna almost be in this position anyway. Maybe not quite that stressed, but you're able to see the DENS process this way as well. Questions about that one? Relax, you can put your mask back on. We'll blind you, sorry. Okay, and then lastly, I'm gonna show you guys the AP axial obliques. All right, so AP axial obliques, we're gonna angle back up 15 to 20 degrees. And still centering in the same place. Down a little bit, right about there. Reline up. For this one, he's gonna rotate his body 45 degrees toward me. Head straight forward. Now, depending on where you're working, sometimes the protocol is to turn the patient's head all the way. And they say that what this does is it gets that jaw away from the spine so you don't have superimposition of the jaw on the spine. But this is pretty site dependent. It's probably the biggest argued thing between techs. Some techs will be like, no, you're supposed to turn the head. Other techs are gonna tell you, no, you don't turn the head. And the book tells you you can do it either way. So whatever the tech prefers.
So for obliques, you can do either side, left or right, and for lateral, it's left.
For the obliques, you do both.
Oh, you'll do both.
So you do, right now he's in an RPO, and we're seeing those left intervertebral foramina. And then when he turns the other direction, that's way too much. Too much. Hold it that way. Now we're seeing those right intervertebral foramina opened up. So it's a 45-degree oblique both directions, okay? And then like I said, with the head, it's either gonna be straight ahead with the body or turned all the way toward the way that they're angled, okay? And then markers with this are kind of tricky as well. So some techs are going to say to mark what you're seeing. So in this instance, or I'm sorry, they're going to tell you to mark which side is down. So in this instance, we're using a left marker because his left side is down. And when he's oblique the other way, we would use a right marker. At UNM and me personally, I always just properly marked the anatomy. They didn't care what marker was on there as long as it was the proper marker. Does that make sense? So with this one, for C-spine, I would just use my left marker for all the views. Okay? Just so I don't forget to switch it. Because if I'm using a right marker for AP and obliques and blah, 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 when I go to lateral, I might likely forget to change it to a left marker.
Why not just have an RPO or an LPO marker?
You could do that too. Well, and sometimes you can mark it like on the image with the computer too. You
Oh,
can,
really?
Like
Okay.
type it in RPO or LPO. So that's all the views of the C-spine. Questions? No? So the other thing is,